All right. Again, good morning, everyone. Thanks for joining us. I will get started by introducing our speaker for today. Dr. Enrica Fung is a clinical assistant professor of medicine in the Division of Nephrology. She completed her bachelor's and master's in public health at Berkeley, followed by her medical degree at UC Davis. She completed her nephrology fellowship at Stanford as well, and then served as chief of nephrology and led the transplant referral and post-transplant program at the Veterans Affairs Loma healthcare system before returning to Stanford. She is now actively involved in several of the VA Cooperative Studies, as well as epidemiological research related to chronic kidney disease. And of course, you all know she's going to be talking to us today about chronic kidney disease and considerations for research. So I will turn it over to her now. And I, again, will provide some links in the chat for you all for upcoming trainings and registration. And then I'll be helping Dr. Fung monitor the chat during the presentation as well today. Thanks.
Okay, thank you so much. And let me just share my screen. Are you able to see it in the slide view now? Okay.
Yep, everything looks
very
good.
Okay. I may not be able to monitor chat, so I think here it will be real nice if you can continue to monitor in case you have questions. And feel free to interrupt definitely if you have any questions as you go along. Thank you for the kind invitation and inviting me to speak about management of chronic kidney disease. I wanted to start off by just talking about kidney disease in general as a general term. So when we were talking about chronic kidney disease, and oftentimes we end up abbreviating at CKD, I think because there is a chronic, of course, there's also an acute side in contrast. So typically speaking, when we're talking about chronic, we are talking about kidney disease that has been going on for more than 3 months. It's a little bit of an arbitrary definition, but that's what the literature defines it as. In settings of acute, I'll just go through very quickly. Sometimes you'll refer to people talking about acute kidney injury. So acute kidney disease or acute kidney injury would be usually defined as one of these terms, including a serum creatinine that rises by more than 0.3 points within 48 hours, a rise of more than 1.5 times of someone's baseline creatinine level. And we'll talk a little bit more about what some of these mean, or a urine volume that's decreased compared to normal. There are a couple of ways that people define so-called kidney function. I'm not sure if some of the previous lecturers may have gone through some of this as well too, but typically the test that we most often use in routine laboratories that we use in the lab is the serum creatinine. There are other markers that are used for research. The gold standard is supposed to be this iothalamate study where this is injected into someone's body, and it's supposed to be the gold standard for someone's pulmonary filtration rate or their kidney function. There are also some biomarkers, some which are a little bit more experimental. There's also something called the 24-hour urine correction for creatinine or urea clearance, which we use in clinical practice as well too. Another test called cystatin C that is sometimes also used in clinical practice as well too. So you may see some of these terms coming up as we talk about kidney disease. Oftentimes when we talk about kidney disease or kidney function, I think most people either when they're seeing a doctor in the clinic or if they are just kind of
chatting until it's time to get down there.
Kidney function in general. They're often talking about the so-called filtering function of the kidney or the ability, and I'm talking about the side that's on the left side of the slide, the cleaning function or the way the kidney is removing or getting rid of toxins or any unneeded electrolytes or extra electrolytes that we get from day-to-day eating and drinking and things like that. That's what most people are thinking of. A lot of times, especially in research setting as well as in clinical practice as well too, we often talk about another aspect, protein. I think I'm going to focus for the purpose of this talk. There's an aspect of protein in urine. I think in Dr. Jackson's Kim talk later on in the series, he probably would end up talking a little bit more about blood in the urine, or sometimes called hematuria. These are basically ways that we can sometimes see that there's basically something wrong with the filter membrane in the kidney. Normally, there should be no protein or no blood in the urine in someone that has completely normal kidneys. Sometimes people can have just one or the other, and not both. Like as in, like they can have only protein urine, but the so-called filtering function could be normal. So I think it's important to kind of try to denote that. So oftentimes, in people that have just protein in urine, that can denote that there may be something wrong with the kidney, that they're at risk of having kidney issues. There's several, if you've been following some of the kidney literature, you will notice, or if you do research in the area of kidney disease, you may notice that there are these different equations that are used to estimate kidney function. So as I alluded to a little bit earlier, and this is something that I feel like if people are interested in, this can be a talk in and of itself. But there are the thing that we actually measure in the blood is called the serum creatinine. But there are equations that we use to actually estimate the kidney function, and we come up with this so-called estimated glomerular filtration rate, oftentimes abbreviated as eGFR. The oldest of these formulas is one that's called the Cockburn-Gault equation, that I would say it's rarely used now, sometimes still used in some pharmacological studies and early in, like, say, phase 1 trials, or maybe phase 2 or phase 3 trials, looking at like maybe drug dosing or so. In the more recently, there is this so-called MDRD equation, but these days, most of the time, the newest equation that we have is called the CKDF equation. I'm only mentioning these because you may hear about these in the literature, or you may read about these if you're reading some papers in the area. There basically are different aspects, mostly including the age and sex, and the race has been removed from the equation. So basically, using those factors, there is a complex equations that based on population level studies that helps in estimating the kidney function. In contrast, the other thing that I alluded to earlier was this concept that people can have protein leakage into the urine, or sometimes called proteinuria. It could be the first sign that there's some level of kidney dysfunction, and oftentimes can be something that becomes abnormal before the serum creatinine does. Unfortunately, for proteinuria, there's many different ways that we measure it in clinical practice, and it can be very confusing, especially for a researcher, especially if you're doing like a secondary data analysis, or if you're doing like big data research, because it's measured in so many different ways. So there is the industry gold standard for many years is to do a 24-hour collection of urine to detect the total amount of protein in urine. That's supposed to be the gold standard. It is subject to some user error, and that's a lot of times patient that may inadvertently either over collect or under collect certain collections over a 24-hour period. The other two methods are just spot urines, meaning that they can just go get a urine sample into a cup and just get a sample that way. So there's a urine albumin to creatinine ratio, or urine protein to creatinine ratio. This can help in detecting these are yes. Okay, sorry. Maybe that was just I thought that was a question.
No, sorry to interrupt you. Just make sure everyone, there's been a couple of people to come off mute. Just make sure that you're muted as to not interrupt our speaker. Thank you.
No problem. And then I think since we paused for a little bit, were there any questions so far? Otherwise, I can answer them as I go along. If not, I think Diana has her hand up.
Yes. Hi, I have two questions. One
Yes.
is, where is the protein coming from?
Oh, that's an excellent question. And what is your second question? Maybe I'll try to answer them both if they are related questions.
Okay. Yeah, so that was one. And then the other one was also similar, like so if you find like trace amounts of blood in someone's kidneys, where is that coming from as well?
Okay, yeah, those are excellent questions. So, one of the main function of the kidney, and we didn't talk about the structure, I guess, in the molecular level, is that it's filtering the blood. So, because proteins and things such as red blood cells are large cells or large molecules, so basically those things they are in the blood because they're normally in the blood, but because there is filtering, um, a filter between where it goes from the bloodstream to the urine. So that's the reason why those things are not supposed to leak out in the urine, normally speaking. But in cases of pathology, there is actually, maybe next time I'll bring a picture and show you guys an example. But basically, there's a breakdown of this barrier. So this causes these bigger and larger things to abnormally leak out. It turns out that there are also sometimes there's also these proteins that are actually excreted in the tubule, that a part of the kidneys called the tubules. This can be a result of some injuries to the cells in the kidneys as well. I hope that helps answer your question.
Hi, Dr. Fung. My name is Jyoti. I have a question. It's related, I'm not sure if you can answer. It's related to pediatric nephrology. We had one of our patients had Bachelor syndrome and was born, and on day one, we knew the patient had a horseshoe-shaped kidney, and that was on an intrauterine ultrasound, and also the creatinine was about 0.67. We found, but there were a good urine output. So, what are the signs you look for in this child as a renal insufficiency, something to classify it as severe renal insufficiency?
Yeah, that's a good question. So unfortunately, I'm not a pediatric nephrologist. I'm going to start off by saying that I think you probably figured that I think all of the speakers for this round are adult, but I think I can answer the question in like a general sense. So, so I think that in the first slide, I was going through some of the signs and symptoms of acute kidney injury. And so decrease in urine volume is one of the signs, but that's not the only sign. The decrease in urine volume tends actually to be a late sign of kidney shutdown. People can have fairly severe kidney dysfunction without having a decrease in urine volume. So those don't always go completely hand in hand all the time. But you're correct in the sense that most of the time, if the kidney has there's severe failure, there usually is some accompanying degree of decrease in volume.
Yeah. Oh, thank you so much.
Yeah. And then going back to the proteinuria, if there are no other questions for now, I will say that because I've encountered this quite a bit myself in research. A lot of times, the creatinine is a lot of times in clinical practice when we're talking about the creatinine, we're referring to the creatinine that's in the blood, but oftentimes a urine creatinine could be detected, and sometimes it's mislabeled in some of those large databases. So that can create a lot of problems when we're doing these large database researches. So it's important. It highlights the important reason why we need to clean up the data. So this is a complicated table, but I feel like it's worthwhile to go through. And again, I think this is I guess it's worthwhile to say that this is actually, this is taken from adult literature as well, too, since I realize now that some of you guys may be working in pediatrics. even though I think a lot of the concepts will still kind of cross-apply. Because I think that the pediatric group actually, I think, uses somewhat different equations actually as well in measuring kidney function. So, so on the left side, just to orient you to this graph, on the left side is the so-called G stages, which are the GFR stages. So these are talking about kind of the different, what I was referring to kind of as the different like creatinine stages. And usually maybe I should start by saying that usually the GFR, in case you're not aware, the GFR and the creatinine are inversely related, meaning that someone with a low GFR tends to have a high creatinine and vice versa is true as well too. So someone with a normal kidney function usually has a high GFR versus like some of the low kidney function has a low GFR. So you can see that G1 through G5, G1 being the best kidney function or normal kidney function, and G5 is the most severe form of kidney failure. And then on the top of the graph, you see the A stages. And these age stages are what I was referring to earlier, the urine albumin to creatinine ratio. So there are different definitions of how severe the albumin is in the urine. So less than 30 is considered to be normal. 30 to 300 milligrams is considered to be moderately increased, and A3, the most severe form, greater than 300 is considered to be the most severe. I think the numbers themselves, I think the categories are not as important, but I think the important concept here is that you can see that there's, first of all, there's some intersection between the two. So I'm sorry, that seems like I think that the slide the color schematic didn't come through, but basically green denotes people that are, at very low risk of progression of kidney disease. Yellow denotes kind of like a mild risk, orange a moderate risk, and red, a red denotes like a very high risk of progression to kidney failure. Again, I think the actual boxes don't matter as much, but the concept behind it is that someone basically with very severe albumin in the urine and also a very low GFR or a very high G stage are a very high risk of progression to complete kidney shutdown, kidney failure, versus someone that has probably like kind of more moderate categories of each, like say like something like G3A and A2 probably has like only moderate risk of progression. And in clinical practice, this usually denotes what the kidney society guidelines recommend for referral to see a kidney doctor. So that's the kind of the clinical significance of that, because not people that have either normal kidney function, obviously, or people that have not too severe forms, not all of them may require to see a kidney doctor in the lower stages, even though some of them are still referred. But for sure, the people that are in the red category should be referred to a kidney doctor. Maybe I'll just check in the chat there.
Yeah, there are a couple of questions. So Donna asked, it's been her experience that surveillance is done with BUN and creatinine and that the GFR is not typically or routinely checked. What would trigger an MD or physician to check the GFR?
Yeah, so this is interesting. So these days, usually the most places that at least I practiced, I can't promise for every single place in every setting, but most places, regardless of the lab that you're checking and say either Stanford or at like say other labs like Quest or LabCorp, when the clinician orders a creatinine level, there will be a GFR that's calculated. So the GFR is actually a number that's calculated from the creatinine. It's calculated by using the creatinine plus someone's age and sex. You can actually look up, and maybe if we have time, I can actually maybe exit the slideshow and just show you there are actually online calculators that you can use as long as you know the patient's age and sex. You can actually calculate out as long as if you have the creatinine number. So this is not necessarily something that needs to be measured separately. It's actually a calculation from the lab value. I hope that helps answer the question. I know, like I said, I think I don't want to misspeak, but I think in pediatrics, I think they use a different equation called CKID, I believe it is. But because I'm not a specialist in the area, I think that I will refrain from speaking too much about the pediatric parts. And then
Monica
what would
asked,
cause
what would cause a false positive?
false positive? Yeah, and that's an excellent question as well too. So sometimes it turns out that I didn't go through this because I didn't want to make the talk too I felt like that may make the talk too confusing. So first of all, sometimes when people refer to proteinuria, it turns out that the methods I referred to earlier, such as checking the 24-hour urine collection or checking that so-called urine albumin to creatinine ratio, the A1, A2, A3 that you see on the chart, or checking the urine protein to creatinine ratio, those are actually more quantitative methods of checking proteinuria. It turns out that if you check something just called like urinalysis, we oftentimes will get something that is just more qualitative. So you'll get some values such as like 1 plus 2 plus 3 plus. Those tend to be influenced by things such as the pH in the urine or how concentrated the urine is. Back in the old days, it's actually the reason why it calls it urinalysis dipstick is that they literally just use a colorimetric assay. It's almost like you can think of it as almost like a litmus paper type thing. So it can be, a lot of things can influence those results. The other thing that can cause false positive is that if there's a lot of blood in the urine, a lot of times, especially since if you think about it, most of the time when the labs are checked, it's not immediately sent over to a laboratory. If the blood cells or anything has been sitting there for some time, that can cause some breakdown of blood cells if there's blood in the urine. So sometimes I would say it's not uncommon for people to have, if they have very significant blood in the urine, even if they don't have too high of actual protein in urine, they oftentimes will have a little bit of protein. So those things can cause false positive. The other things that, this is getting more into esoteric territory, but especially in younger folks, they think that there are some people that end up getting something called postural proteinuria, where it seems like some people that have been standing around for long periods of time. So in the classic example, maybe someone that's in the military or someone that is doing some strenuous activity or something like that, that can sometimes cause false positives as well. Yeah. And then I think it looks like Diana had a question. The creatinine equations, is that something that the clinician can do if they don't have the GFR? Yes, you can calculate it. Maybe I think just because I feel like I had some technical difficulties early, so I'm a little bit scared to exit the slide. But and then go to because I can maybe show you the calculator online, but if we have time in the end, maybe if I exit out the slideshow, I can show you the calculator. There's actually if you guys are interested, you can actually Google something called the MDCalc, MDCalc. And there are some calculators on there. I believe that the CKIT calculators on there as well too, if you're interested. Diana, you had your hand up.
Hi, yeah, I can elaborate on my question sort of. So I guess I was wondering, when you look in Quest or even in Epic, it doesn't look like the GFR is always in there. And so I wasn't sure if that's something that, you doctors, if you have to kind of do that once you get the creatinine, or sorry, once you get the labs come through, or if that's automatic, but it has to process after the other labs come in.
Yeah, I would say most of the time it does process, and with basically, I think the labs automatically calculate it. The other thing that you may be running into is that sometimes people end up checking other labs together with the creatinine, so you end up with different ways that you estimate GFR. I didn't go through the specifics of that in this talk. So that may also be the reason why, but certainly if for whatever reason, I'll give you an example. There was a patient that I saw last week where it turns out that his chronological age, he told me, is actually 4 or 5 years older than what the chart age shows because of some, I don't know, some error in his birth certificate or something like that. So technically speaking, I know that the GFR that the computer spits out may not be the most accurate. So in those type of situations, where if you have some doubts, you can go back to, calculating out manually. And I think, Donna, you're correct. I think that there are some calculations that I think in drug dosing, they oftentimes may use a calculator. I think sometimes they may end up using the in drug dosing settings. I think sometimes they would default back to the Cochrane Gulf just because a lot of the I would say a lot of the original studies were actually using the older equations, and not all the studies have been redone using the newer equations. So it's I think a lot of people think that they are interchangeable, but technically they're actually not quite the same. Yeah. Okay. Okay. And then I think another concept I think we often don't talk about as well too in management of chronic kidney disease, because I feel like this is actually something that honestly I think most patients are interested in. Because I think if you're talking as, especially if you're practicing clinically, I feel like most patients really don't care about, or they care, but as in like they don't feel, they perhaps don't really feel that differently, between like say a creatinine level of like 1 versus 2 or something. They're like, I feel exactly the same. I don't have any symptoms. Why should I care about this? They probably, I think, at the end of the day, care more about, what are my chances of actually needing dialysis in the next 2 years, next 1 year, or next like 3 to 5 years. I think in the end, that's what I would argue saying that that's what we are also concerned about as well too. And I think a lot of times in research, that's what we're also concerned about at the end of the day. So there are these kidney failure risk equations. I think the most famous one that were developed by Dr. Tongri and their group of researchers. This is again this was actually based on like, 2 large studies that were done, but there is actually a physical calculator that's also available in MedCalc, I believe, or MDCalc, I believe. But they're based on things that you can think of, like such as age, sex, the GFR, the albumin to urine albumin to creatinine being the factors that need to be in there in order to calculate the so-called KFRE, or the kidney failure risk equation. Some of the parameters I put in parentheses, such as the serum albumin, the phosphorus, the bicarbonate, and the corrected calcium, those are optional categories, but they are helpful if you have them, to put them in to give you a better estimate of the risk of a complete kidney failure, and like, need a person requiring dialysis. Okay. Maybe. So I think it will be a little bit hard to remember because I think it's been a while since we discussed this, but I think I thought that I would just take a poll. And I don't actually have a poll function on here, but if you compare someone with a GFR of greater than 90, but a albumin urea or urine albumin to creatinine ratio of greater than 500 versus someone with a GFR of 35 with no albuminuria or albuminuria of 0, what would be the risk of development of, or it like I guess the risk color, I guess you can call it, or like the degree of risk. Yeah, so I think Diana answered high, and I think that will be kind of like, I think in the I'm not sure if you're referring to both categories or to just one or the other. Maybe I'll start off with asking just the first question. So whoops. So the first one would be a GFR of greater than 90 and a albuminuria of greater than 500. So that would be, whoops. So it will be G1 and A3. So that would be the orange category. I guess in the color, meaning that there's moderate risk of development of kidney disease. And then versus, maybe next time I'll have a real poll and that'll be easier for people to answer, versus like I think GFR of like 35, around 35, and no albuminuria. If I go back to this one, right? So the GFR of 35 will correspond to maybe someone can try to type or just unmute themselves and see like which G category that would be. Yeah, that'll be moderate as well too, because it will be G3B A1. That's correct. Yeah, so I think my point is just that I think that there will be times where, you know, someone may have a normal G category and very high protein, where they would still have moderate level of chance of developing or risk of developing kidney like severe kidney failure, versus like someone with like kind of a decrease in kidney function that most people think of the G phrase and no proteinuria, that they actually turn out to have the same category, at least by the definition of this table. Okay. And then I thought I'll just spend a few minutes at least talking about the different risk factors for developing a chronic kidney disease. So it turns out that, interestingly enough, even though I feel like most people don't follow that this guideline, it turns out that if you read the U.S. Preventative Task Force guidelines, technically speaking, there is really no strict how would I say, like a strict guideline in terms of testing kidney function for everybody that goes to see a clinician. Although I would say that arguably most people have at least some risk factors for developing some degree of kidney disease. So at least I would say in the adult world, I think that most people, I think that if someone were to go to see their primary care doctor, I think most people would end up getting it checked at least once a year. And it's a simple blood test. I think most people would end up doing that, or urine test. So I would say the most common risk factors will be in the at least in the United States, will be hypertension or diabetes. Cardiovascular disease is definitely a big factor. Any prior history of acute kidney injury or acute kidney disease can be a big risk factors. In areas that, in certain geographic areas, there are these other variants that, again, maybe I think for someone that's interested, and maybe, I don't know, maybe someone in the group is doing disease studies in this area. I know for sure that some people in our group are doing studies in these areas. Areas where they have CKD of unknown origin, they call it, or CKDU, or there's some genetic variants that are actually more common in African American people of African ancestry, called APOL1 genetic variants that can lead to a higher risk of developing CKD. Genital urinary disorders are especially common in the pediatric world. So some people are born, unfortunately, with some structural urinary tract disease. I think that's, I forgot, I think it was Jyoti who asked earlier regarding that. Or recurrent kidney calculi, recurrent kidney stones can cause problems. Some systemic diseases can also lead to a higher risk of developing kidney disease. So I think that there have been some, I think, recent cases and I think in the I think that was in the news that, you know, people with systemic lupus erythematosus or SLE or lupus can develop kidney disease. Some vasculitis, some infectious disease such as HIV can lead to kidney disease. And then there's like, I would say that there's a whole slew of other things too, including some like gestational conditions that I think people are becoming more and more interested in. Another common genetic disease is something called polycystic kidney disease, or PKD. That is also a very common cause of kidney failure. And then there are some environmental exposures to chemicals such as heavy metals, pesticides, hydrocarbons that can lead to also chronic kidney disease. So we already talked about this a few times now, but I think that the usual basic workup in the beginning for chronic, for honestly any type of kidney disease is, checking usually they call it basic metabolic panel. Some places they call it a panel 7 because there are 7 things in this panel. So it includes various different chemicals, and it does include the BUN or blood urea nitrogen and the creatinine level, as well as these other chemicals that are listed here. A lot of times we do think that it's helpful to additionally check the serum albumin, which is different than the urine albumin, but it can help to determine nutrition status. In addition, there are some corrections that can be done depending on the albumin level for calcium levels. So we'll oftentimes check that. And then urine studies to detect blood and protein in the urine. And then kidney imaging can be helpful. I would say most of the time we do recommend some kidney imaging. I think that there's some variation depending on the cause of kidney disease, that some people may not always check that, but I think that some degree, especially if it's never been checked, some degree of kidney imaging can be useful. Yes, I think Diana has a good question regarding whether like kind of neurological disease, I guess, can affect kidney function. Absolutely. Like some neurological conditions can. So people can develop this condition called neurogenic bladder. So basically, if you're not able to completely empty the bladder because of some neurological conditions, that can lead to urinary retention, and then if it's severe and it's not detected early enough, that can lead to backup of the urine, and over time that can cause kidney dysfunction. Usually, if it's detected early enough, that could be reversible. But if it's detected late, like say if it's been going on for like several months to years, by the time someone detects that problem, it may not be a reversible problem at this stage. And sometimes, again, this is a little bit beyond the scope of this talk, I feel, but sometimes people may wonder why, like, hey, if I have a blockage, how come I don't have symptoms? It turns out that I think a lot of times people don't have complete blockage, or they may only have blockage on one side of the kidney and not the other for some reason. And assuming that the person has 2 kidneys, which not everybody does, but if they have 2 kidneys, and if one of them is blocked, they may not actually have symptoms. In many cases, even for people, for instance, even with kidney stones, for example, kidney stones can cause a slew of different problems. But most people, if they're actively passing a stone, they may have symptoms. But if they just have stones that are blocking a little bit in the bladder or in the kidney, they actually may or may not have symptoms. So that can sometimes be missed. So I talked a little bit about this a little bit earlier, but I feel like it's helpful to actually delineate and talk about this. I think oftentimes when, I like to think, because I'm a nephrologist, I like to think that, or sometimes I'm like, I think mistakenly that, we're the only ones that manage it. But of course, we don't. That's certainly not the case. I would say that if anything, we're actually probably, by the time the patient comes to us, it's probably already, fairly late in the referral process. Interestingly, I think that there have been researchers that are interested in health services research that have looked into these areas in more detail. There are cases where I think people that have kind of really high risk of progression, that people kind of in the red categories are referred to, where there's an under referral. But I think if you're talking about generally speaking, there a lot of times primary care doctors do end up managing a lot of people with mild forms of kidney disease. Urologists oftentimes end up managing more of the structural aspects of kidney disease, or for instance, people that require surgical intervention, such as for kidney stones or any type of bladder issue. We oftentimes do also co-manage a lot of times. I think a lot of my colleagues, for instance, have like an onco-nephrology practice, practicing alongside with our oncologist colleagues, or some people are also more interested in cardiorenal or heart, does the intersection between heart and kidney. Some people are also interested in the intersection between liver and kidney. So there's definitely a lot of cross section, because the kidneys are one of these organs that unfortunately are affected by other the function of other organs. So we definitely collaborate with many other providers, and I think there's definitely certainly more push these days to have a more multidisciplinary team with to work with other providers and pharmacists, dietitians, to work together, because it's certainly not just about the medicines, although I think that even though that may be the focus of the kind of future slides that I have in here. And then there was actually recently one of our senior colleagues and former chief in our division, Dr. Glenn Chertow, talked about this kind of interplay between chronic kidney disease and cardiovascular disease and metabolic syndrome. I think that's definitely much more recognized now in the recent years. And this is the reason why we have to work together, because I think that this is in the clinical practice, in at least in adult medicine, I think this ends up being kind of a very large portion of patients that we see in our clinic. So maybe I'll pause here for a second and for questions, and also to maybe we'll talk about, because we're going to move on more to talking about actual management of kidney disease as well too, because I think some of the stuff that I talked about earlier is actually more background. So what would be the goal of management of kidney disease, or what things can you guys think of in management if you were the clinician? Or what things, I guess, if you are more thinking in the research lines, what would be things that you'll be interested in researching of that would be things that would be important for management? Certainly, I think Chun Yun says delaying progression. So I think that will be definitely one of the main goals, both for the clinician side as well as for the patient's perspective, patient and family perspective. Anything else anybody can think of? Oh yeah, that's very good as well, Nicole. So effects on other organ systems, certainly I think that there's a bi-directional relationship. So I think and I think Ali said cardiovascular morbidity. So I think you guys are all hitting the high points, right? So there's we say actually these days that most kidney patients or people with kidney dysfunction actually don't die specifically from kidney failure specifically anymore, unless they refuse dialysis or are not candidates for transplant. Most people actually die from cardiovascular disease. So I think that's certainly a big thing. And I think Monica said delayed dialysis, which is definitely I think a big thing for patients as well as for us as clinicians. And then Diana Fisher, quality of life will be important things. And I think those are all good points. So for purposes of just time-wise, I think I'll move on. These were all the things that I could think about in terms of what I manage. And I think you guys basically hit on everything that I said and more as well too. There are kind of, I just kind of delineated a little bit more in detail, kind of specific things. But I would say, honestly, the main things or aspects of management is that, first of all, I think most people already know this, but I think we just didn't actually delineate it right. Obviously, we wanted to make sure that if there's anything reversible, we wanted to correct that. And then, I think preventing progression is a big one. We wanted to make sure that drugs are dose appropriate. I think someone actually mentioned that already as one of the questions earlier on. Treating any symptoms that may arise, I think could be important, even though it doesn't necessarily prevent progression necessarily, but I think that's still important, obviously, from a quality of life perspective. And then some of these other specific things that we'll talk about management of, and then if um, if it's within the goals of care for the particular patient, at some point, if we're not able to prevent the progression, then preparing someone for replacement therapy, such as dialysis and transplantation. And, of course, we always work together with the patient and family with any other goals that they may have. Sometimes patients may have very specific goals, such as that, I wanted to make sure that I make it to the special event, or, I wanted to continue to be able to travel. Those are all, I think, important aspects of management. So I think the next few slides will be kind of a little bit just things that I thought I'll mention, just because sometimes that may be encountered both in clinical practice as well as I think in research. I think the anemia management in chronic kidney disease is already pretty well established now. There have been a few kind of studies that were done a while ago now that kind of has established it, although there are some new drugs that came out in the past like 2 years or so that are newer in terms of management of anemia. But the basic premise usually behind the management of anemia and chronic kidney disease is that first of all, the kidneys do help in producing one of the hormones for stimulating the bone marrow to make red blood cells. So that's one of the reasons why, among other reasons, why kidney patients may become anemic. So we usually recommend checking iron levels, because if the iron levels are low, we usually try to replete those levels first. And then there are some clinical guidelines in terms of when the levels drop below a certain level, typically less than 10 or around 9. That's when we think about starting erythropoietin stimulating therapies. But there are some newer therapies now called HIF inhibitor therapies that can be used. But I think that generally speaking, we're still usually using erythropoietin stimulating therapies. There are many other chronic diseases that can cause anemia. And then in terms of other electrolytes or acid-base disturbances, again, these are things that I feel like from the patient perspective, probably not that important, because unlike anemia, most people won't actually feel any differently if their potassium is a little bit high, or if their acid level is a little bit high in their blood. But these are important aspects too, because high potassium can cause arrhythmias, and because high acid levels over time, it has been shown to cause more rapid progression of kidney disease. So we do like to manage these aspects, even though most people are relatively asymptomatic. So I would say in general, unless it's very severe, there are medicines available in each of these categories in managing these disturbances. So with low sodium, there are other types of management as well too, but one of the management will be restricting free water intake. There are certain types of, depending on someone's volume status, there are some diuretics that can be used as well too to help treat that. High potassium levels oftentimes are treated with dietary changes or adding potassium binders, which can become available. Sometimes also treated with diuretics or water pills. And then as accumulation, you can actually add various formulations of bicarbonate levels, either by mouth or in IV if it's in the inpatient setting. And then it turns out that these type of problems actually can be fixed fairly rapidly with dialysis if it becomes like an urgent issue. And then I think that, again, I'll talk a little bit about drugs, because I feel like this has actually become more and more kind of in the forefront of management in the last like years or so. So generally speaking, there a lot of times we do say that we need to help to manage blood pressure in people who have kidney disease. It turns out that there's actually also a bi-directional relationship there, in that some people may have kidney problems because of high blood pressure for many, many years. The converse is also true, in the sense that people that, even if they don't have hypertension or high blood pressure to begin with, if they've had kidney problems for a long time, they end up developing hypertension, or people are more likely to have hypertension if they have kidney disease. So for all those reasons, it's important to manage blood pressure. There's a lot of different blood pressure medicines that one can pick from, but from a kidney disease perspective, oftentimes we do recommend to pick something in the renin-angiotensin blockade category, either a angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. And then the other category is there are these mineralocorticoid antagonists that are medicines are in a similar category. The old medicine is the spironolactone. There's actually the finerenon's actually only been available now for the past number of years as a relatively newer drug, but that's also available. Unfortunately, both of the medicines that I just mentioned, both those so-called ACE inhibitors or ARBs, or the mineralocorticoid antagonists, can cause high potassium, so they can lead to some side effects. And then the medicines that are in the sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors, have become more available now in the past number of years, and there have now been multiple studies that's shown that it seems like this is a class effect and that it's effective against treatment of progression of kidney disease. So it's very frequently now used as an additional therapy. And then I'm sorry for the typo. I didn't realize that until just now. There's now there's also a glucagon-like peptide 1 agonist. So they call it GLP-1 agonist. So I'm just going to say the semaglutide is the one that was actually studied in the literature, but there's other ones that are available. So these are used partially as weight loss or diabetes drugs, but they at least the semaglutide has been found that it's useful in progression of kidney disease too. And most people do think that there probably is some degree of a class effect there as well too. And then the other things I'll mention briefly, because some of them do have evidence, but others, honestly, the current literature is a little bit varied in terms of the degree of evidence. So there is this aspect of managing mineral bone disorder. So it turns out that people with kidney problems, if it's chronic, do end up developing weak bones over time for a variety of different reasons. From a physiological point of view, the main thing is that because phosphorus tends to accumulate as one of the chemicals in the blood, because the kidneys help to excrete it. So over time, there's a hormone called parathyroid hormone that's affected by it. So we usually say that we wanted to manage it by reducing phosphorus and sometimes using some vitamin D type medicines. Unfortunately, this is one of the categories in medicine where, in general, the evidence is not very strong. There are other categories I mentioned earlier where the evidence is a little bit stronger. So there's still a lot of active research in this area, among others as well. And then a lot of times we think of cholesterol medicines or management of cholesterol in the cardiovascular category, but it turns out that this is also an important aspect of management of kidney disease as well. And then finally, I'll just mention that there's a lot of controversy in this area, but there is an aspect that we often do say that it's a little bit counterintuitive, I think, for some folks, but if we're talking about all comers, there is this thinking that we don't want to overly increase the amount of protein intake for most people with kidney problems, because it may be causing more stress to the kidney. So there is a kind of nutritional recommendations for most people that are pre-dialysis. And then we may have talked a little bit about this a little bit earlier, but I thought that I'll just mention as well too that from the patient's perspective, this is not meant to be a all exhaustive list, but these are some of the signs and symptoms of kidney failure. So the first thing people may notice that is they may have symptoms of volume overload. So like either swelling in the arms and legs, or maybe fluid accumulation in the belly causing ascites, or fluid in the lung causing like a pleural effusion, or just kind of pulmonary edema, they call it. And then they can also have this whole syndrome called uremia, which is unfortunately a little bit of a misnomer, because the name implies that it's directly related to the urea levels. Turns out that it's not directly related to it, because it turns out there's other uremic toxins, so-called uremic toxins, and turns out that urea itself is probably actually not the main toxin. But in any case, when we're referring to toxin buildup when people have kidney failure, it can cause a lot of non-specific symptoms, but most of it is confusion, feeling a lot more fatigued than usual, not having energy, symptoms such as nausea, vomiting, or feeling like food is not tasting the same, or having a metallic taste in the mouth. Some people can also have some itching. Those are all signs of toxin buildup. They can be a lot more frail, and they appear malnourished, or they may be losing weight. They say, I think, if you're on the clinical side of things, they usually say that they're the so-called AEIOUs of dialysis. So those stands for if someone has acidosis, electrolyte problems, if they have had ingestions of toxins, if they have signs of overload, if they have signs of uremia, that could be indications of dialysis, although some of these can be managed medically. Uremia is one of the ones that, unfortunately, or the buildup of toxins really is the one that not having dialysis cannot replace. Kara, I just wanted to check with you on the time, because I have a few more slides that talks a little bit just about dialysis and transplant, but I know that there may be other people that already talked about it. So if we're kind of coming towards the end of time, I thought I could skip and maybe just give people opportunity to ask questions, or maybe just show them some of the calculators, since some people seem to be interested. I don't know.
So we have until 10:30. So
okay.
we have a little bit of time if we wanted to, finish your slides and then.
Yeah, and then we can just go through. Okay, thank you. I just wanted to ask. Okay.
No problem.
Okay. So I wanted to just start off by asking, or talking about a little bit about transfer referral. Again, I don't want to spend too much time, because I know that I believe that there was another lecture talked about transplant, but I don't know if the speaker at the time went through the process of transplant referral. And this, I think actually I should probably say that this again is specifically talking about the adult side, because I know that for the pediatric side, the process is quite different. But for adults, listing can generally be made, or people can be referred when their GFR level is less than 20. So the goal or the idea is that you want to try to refer shortly after a steady level of this is reached, because if someone is referred in an appropriate manner or in a timely manner, even if they haven't started dialysis or other types of renal replacement therapy, they can actually start accruing time once they've actually gone through the whole transplant referral process and actually finish all the testing, and they're deemed a candidate and they're actually listed. They can actually start accruing wait time. If the patient is referred after they've already started dialysis, so say this actually happens not infrequently, where someone may unfortunately need to be started on dialysis, or like they may not have been seeing a doctor for some period of time, and then we get surprised and they needed to start dialysis and permanent dialysis. I'm not talking about temporary dialysis where someone recovers, but permanent dialysis. It turns out that if they are referred, and if they are referred later on, the waiting time can actually be backdated retroactively to the date of the first dialysis. So if you, I don't know if any of you use the large databases, the USRDS or the US Renal Data System database, but it's called the first SE in this database. that is actually a US-wide large database that tracks everybody that has had a dialysis or that has dialysis or deemed to have renal failure. And then in some cases, it turns out, especially in the pediatric world, and actually it happens too in the adult world, I've had some in the adult world as well too, you can have a preemptive transplant so that you prevent actually needing to start dialysis to begin with. So you try to give someone a transplant before they need dialysis, which will be ideal. I would say in most cases, most people do think that for people that are transplant candidates, which is beyond the scope of this discussion in terms of, who is a transplant candidate, but if they're a transplant candidate and if their, health is good enough in most cases, having transplant is preferable to doing dialysis in terms of both quality of life as well as morbidity, mortality. Dialysis is a very big topic, and I don't pretend I'm able to go through that in like a short, 5-10 minutes, but I think that for a talk that talks about management of chronic kidney disease, I think we have to at least spend a few minutes talking about dialysis. So there are two types of dialysis. There is a hemodialysis or blood dialysis, and then there's also a peritoneal dialysis. The hemodialysis, I would say typically it's done in center, although there actually is a way to do it at home. In the United States, peritoneal dialysis is pretty much only done as a home modality, so you cannot go to like a clinic to do it, although in some other countries it may be available as an in-center option. So hemodialysis is actually the most prevalent method of dialysis in the United States. Ideally speaking, we want to have so-called a permanent access. So a vascular surgeon would have to create something called a fistula graft, and usually in the arm of a person or forearm of a person. So ideally, you want to prepare someone or if you think that they're getting very close to have some lead time for the surgery, because this type of fistula graft requires some sort of repair. There is a requirement that when people are getting hemodialysis as a form of therapy, that they need to see a nephrologist at least once a month. And some of the medicines that I discussed a little bit earlier, such as like iron or some of the management of the mineral bone disease, some of the medicines that are used to treat anemia, can be provided with the in-center, as well as actually even if they're getting the home dialysis. So sometimes that can help to increase the adherence of medicines because we're providing them when the patient comes into clinic. Peritoneal dialysis, even though it's not as common in the United States, in many ways, I think that many patients actually prefer this as a modality. It actually involves putting in a catheter into the abdominal cavity, into the peritoneal space. Typically, ideally, like maybe about, depending on what you read, about 2 weeks to a month before you anticipate someone needs this form of therapy. There is this thinking of the so-called urgent peritoneal dialysis starts where you can use the catheter right away, but in those type of situations, you would have to do a modified type prescription. So for someone that we are knowing that, or we're anticipating that they would need dialysis, ideally you want to place it a little bit earlier. And honestly, a lot of times I found that depending on the place that you practice in, not every place have surgeons that do this type of surgery, even though it's actually a very simple surgery. It turns out this can be a barrier to starting this type of modality if you don't have a surgeon in your area that can do this type of this procedure. Because it is something that's done at home, it does also require some training prior to start of therapy, or someone that can assist the patient. And it also does require, it has some requirements at home in terms of basically a clean and safe environment to do it at home safely, and an area, for example, to store all the supplies. There are some solutions that need to be used along the machine. So those things, the patient needs to have a home environment that allows for that. And the minimal requirements is actually pretty similar from the clinician's perspective in that there is a doctor's visit that's required at least once monthly for this type of modality as well. And maybe I will just, this is kind of the end of the slide deck, so I was just going to pause for some questions, and then, like I said, maybe if there's no further questions, I can show you guys some of those calculator things. You guys can feel free to unmute yourselves.
Any other questions? You can always wrap up early. I know people always love some time back. So that's
I know. I think some time back is always good, but I think since we do have a little bit of time, what I could do, if you guys want, is I could just share this kidney failure risk equation assessment tool just to give people an idea of what it looks like. You can actually just search for it. So let me see if I can just share. Hold on one second. I think you can see my screen now, right, with the kidney failure risk equation. So you can actually just search for this online. It's actually the first thing that comes up on Google. So again, just to give you an idea, you can actually just put in things. I'm just going to make things up and just put things in. So for instance, if you're a 51-year-old male who's from North America with a GFR around 32 and an albumin, I'm just going to pick someone with kind of like a moderate level, maybe 68 milligrams. And then I'll just show you there are these other parameters that you can put in. Maybe I'll just, again, just put in some random numbers in here. So you can see that the calculator basically spits out. So first of all, it actually interestingly, right? So it gives you that kind of the values that you put in here. And then it will tell you that this patient is in the stage 3 or the G3 stage of kidney problems. And then you can see that it gives you the stage, and then it also gives you the glomerular filtration rate that you put in. And then it gives you the patient's risk of progression of kidney failure to the point where they require dialysis or transplant at 2-year and 5-year mark. So sometimes that can be helpful in counseling patients. I have a feeling that I think maybe over time they may also revise these equations as well too. So I think that that's one calculator that can be useful. The other calculator that you can use is that there is like I said, there are multiple different GFR calculators. This MDRD equation is a little bit older, so I think people have been moving away from this one now. So the CKD-EPI is the one that's a little bit newer. And I would say it depends on what values you have available. Most people, the 2021 equation is the one that does not include race that they usually recommend. You can use either this one or this one down here, which is the creatinine cystatin C one. If you also have a cystatin C value, basically what it does is that it would kind of do almost like an average of the two, but I'm just going to pick the CKD-EPI creatinine one for the purposes of this demonstration. So again, maybe I'll do a 52-year-old with a serum creatinine of 1.7, for example. So you can see that if for a male age 52 with the serum creatinine of 1.7, their GFR would be 48. So there will be stage 3A or stage 3 G3A by definition. So you can actually, if for some reason your lab doesn't calculate the value, it's a little bit extra work, but you can go in here to calculate it yourself. It's also available as an app. So that's all I have. I think Diana, you had your hand up.
Yes, thank you. I don't know if you mentioned this earlier, but you may have. Did you say, are there differences in kidney function based on race?
So that's a good question. So back in the day for a little while, like before 2021, there is a equation that includes race. There has been a move away from that since the 2020. So if you have a reason why you needed to use those equations, the older equations, I think, include race in there, as you can see. But I think the societies don't recommend using these equations anymore. Although I will have to say that I think you if you are interested, you can play around with these calculators. It turns out that the difference, even if you put in the race, is usually not too huge of a difference in terms of the GFR value. But they're not recommending to use the equations with race anymore. So the newer equations in 2021 does not include race. I think the MDRD still does because it's an older equation. And then Monica did ask, I saw in the chat, would you elaborate on when to advise patients regarding fluid intake? Yeah, that often actually comes up. So the fluid intake, it turns out that it actually has more to do with sodium levels. So if someone has really low sodium levels, I usually will recommend some degree of fluid restriction or fluid not taking enough fluid or decreasing the amount of fluid or just drinking to thirst. Now, there are some people that probably are not drinking enough fluids, but I feel like most of the time, depends on the situation. But in most cases, unless someone is like extremely dehydrated or something, usually increasing fluid, beyond the extent of necessary doesn't necessarily decrease a kidney or increase the kidney function. Let's just say it may dilute down the blood a little bit, so it may cause the creatinine to go down a little bit, but it may actually not cause a actual change to the kidney function. It's a little bit different in the transplant world because I think that in the transplant world, some of the patients may be a little bit more prone to having being volume depleted, or they only have one functioning kidney because they had a transplant. So I think the recommendation is a little bit different in transplant and maybe in dialysis. But I think if you're talking about people that have general chronic kidney disease, I don't usually have like a strict recommendation. I usually say, unless there's some unusual situation, like I said, with like maybe low sodium, or someone say who's like losing a lot of fluids because they're having diarrhea or something like that. I usually just say that just try to drink to thirst. It's not necessary to try to push a lot of fluids or try to restrict the amount. If they're having swelling, a lot of times it's more advisable to try to decrease the sodium intake first, or use diuretics before you think about fluid restriction.
So Dr. Fung, this is Monica.
Yes.
I work with a lot of elderly
Mhm.
patients, and most of them, one of the questions they ask would be, well, then how much water should I drink per day?
Yeah, I get that a lot as well too. I say that, if you're thirsty, definitely, drink some water. The other thing that I usually do, because I feel like it's sometimes difficult to, recommend exactly how much they are. I think somewhere, but six to seven glasses of water, I think is certainly reasonable. The other thing I often ask them to do as well, if they're sophisticated enough, is that they can also look at the color of the urine. So if it's starting to look like it's very concentrated, they probably are not drinking enough water. So you want it to really be like kind of like a light straw color is what you would usually recommend. So I feel like that's actually more useful because I think sometimes, like you're saying, depending on their activity level, the fluid intake may be different. Or say, even for an elderly patient, if they were, say, out and about last week where it's like extremely hot or hotter than usual, they probably are losing more fluid, especially if they're outside. So that's why I feel like titrating more to thirst or maybe to urinary concentration may be more useful.
Thank you.
Thank you, Kira.
Yeah, thank you so much. This was great. Thanks all for joining. And please reach out to me with any questions. I will send out an email today, tomorrow with the evaluation as well as the slides for your reference. And I hope to see you all at a future education opportunity with SCCR, and have a great rest of your Monday.
Thank you. And you guys can feel free to email me too. I mean, I'm sure you can find the Stanford email, or you can get it through Kara as well, but I'll just put it in the chat as well.
Okay. Yeah, I can CC you on the email so you're connected.
Yes.
Thanks,
Thank you.
everyone. Have a great day.